everyone. I'm Mrs. Princey, Associate Professor in Mental Health Nursing. There was a 16-year-old girl who got admitted to the psychiatric hospital with the complaints of decreased sleep, irritability, excessive happiness, irrelevant and increased speech, and also she used to use the abusive words to her parents. She also had the delusion of grandiosity wherein she used to tell that she is Lord Shiva. Okay, and these symptoms were lasting in her since 4 days. If you take the personality or the pre-morbid personality of the girl, she was basically a very introvert girl who always kept herself isolated, and she also did not maintain good relationship with her family members, friends or her neighbors. She also had a fear of getting less marks or scoring less marks in a 11th standard board exam. So for this, she was on the regular treatment and follow-up, but she also developed certain other features like feeling very sad, not interacting with the family members, and also not able to maintain the activities of her daily living. So when she came to the psychiatric hospitals, they had done the investigations, the history taking assessment, mental status examination, and finally they diagnosed her as having bipolar affective disorder. Yes, the topic for today is the bipolar affective disorder. So, as the name says, bipolar affective disorder, okay, we have got the two poles on a line, okay, wherein there are two conditions in the same patient at the same time, which is called as bipolar affective disorder. So, let us see in detail about this topic. Bipolar affective disorder is otherwise called as manic depressive episode. Here, the patient shows both the symptoms of mania and depression. When the client is having the manic episode, he will have the symptoms of elated mood, feeling extraordinarily excited, confident, filled with ideas and being restless. So when the patient has got a depressive episode, the mood of the patient or the emotions, behavior of the patient will be opposite to that of mania, wherein he will have the symptoms of sadness, loss of interest in almost all the activities. He'll have a low energy and also he will be sadly pessimistic. Okay, he will be having negative cognition. So that is the meaning of the bipolar affective disorder, wherein in the same patient, there are both the conditions of mania and the depression at the same time, okay, which we call as the bipolar affective disorder. Right. So if you take the bipolar affective disorder, we have got different types based on the degree of mania and depression. Sometimes the patient may only experience temporary irritability with longer periods of depression, thus making a misdiagnosis of having the unipolar depression. Right? So you have to be very careful to find out when the patient is having the mania or the depression, to know the history so that you can make a right diagnosis. Moving on to the types of bipolar affective disorder, we have got mainly the four types. Number one is bipolar 1 disorder. It involves one or more mood swings which will be lasting for a period of 1 week, sometimes which causes severe manic episode along with the hallucination and delusion. So that is called as bipolar 1 disorder. Moving on to the second one, which is the bipolar 2 disorder. It is a milder form of bipolar affective disorder. We can say that the patient will experience milder episodes of hypomania for a period of 4 days. So that is called as bipolar 2 disorder. The third type we have is the mixed bipolar affective disorder. Here, the patient will experience both the symptoms of depression as well as elated mood swing. So that is called as mixed type of bipolar affective disorder. The last one, the fourth one, we have rapid cyclic affective disorder. So as the name says, rapid cyclic, very rapidly there is a cycle of mania and depression that you can see in the client. At least in a year, there may be 4 episodes of such cycles. So if you take a period of 12 months, in the 12 months, the patient will experience at least a minimum of 4 episodes of changes in the mood. It can be episodes of hypomania with the depression. So likewise, there is a rapid change in the mood swing, right? So this type of bipolar affective disorder, it seems to be very serious compared to the other types of the bipolar affective disorder, because there is a rapid change in the mood. Within a year, 4 times there is a change in the mood, right? So these are the types of the bipolar affective disorder. Moving on to the classification of BPAD, bipolar affective disorder, based on the ICD-10 classification. F31 is a chapter which describes about the bipolar affective disorder, BPAD, with the current episode of hypomania. F31.1, BPAD, current episode mania without the psychotic symptoms. Then we have the next classification, which is F31.2, wherein the patient is having BPAD with the current episode mania with the features of psychosis. F31.3, BPAD with the current episode mild to moderate depression. F31.4, BPAD with the current episode severe depression without the psychotic symptoms. F31.5, BPAD with the current episode severe depression with the psychotic features. F31.6, BPAD with the current episode which is mixed, right? So there is a mixture of both the mania as well as depression. So this is about the ICD-10 classification of BPAD, bipolar affective disorder. Moving on to the etiology or causes of bipolar affective disorder. There is no single cause. We have got some hypotheses wherein we find out the first one is the hereditary. If there is a client, or a patient with an identical twin, as well as the family history, especially the first degree relatives are affected with the bipolar affective disorder, there is an increased chance for the family members also to develop the bipolar affective disorder. That's the first one, which is the factor of genetics or the hereditary. The second cause is the structure of the brain. So they have done the CT and MRI of a brain with the bipolar affective disorder client. They found that there are some structural changes in the brain of the patient. The third one is the maladjustment or the imbalance in the neurotransmitters. So they, especially these neurotransmitters like dopamine, serotonin, noradrenaline becomes, imbalanced in the bipolar affective disorder. Next cause is the hormonal change. It's found that the client with the endocrine disorder or any kind of a hormonal change is at more risk of developing the bipolar affective disorder. Other factors which contribute to BPAD is the stress, and use of certain medications or drugs for a longer period of time can also result in the bipolar affective disorder. So this is about the etiology or the cause of bipolar affective disorder. Moving on to the clinical features of BPAD. So as I told you, there are both the features of mania and depression in the same patient, but at different times, right? So if you take the current episode of mania, BPAD with mania, the patient will exhibit symptoms of mania only, right? So let us see the symptoms of BPAD during the manic episode. The first symptom is the elated mood. So as I told you, the elated mood, there is the elevation in the mood, the expansion in is mood, wherein the patient continuously shows the excitement, enthusiasm, he gets the pleasure, and also he gets angry easily. He will stamp the anger even for the trivial matters, the small matter which is very much unimportant matter also he feels very much irritable and angry. And also he shows a very poor self-control. So that is the first symptom that you can notice in the manic state wherein the patient will have the elevated mood. The second symptom that you can notice is crazy thoughts. Here the patient appears to have the, over talkative behavior. Okay, he will talk irrelevant items, and also he'll have the flight of ideas, the crazy thoughts that he will have with the hoarse voice, and also he will share the delusions, right? The delusion of grandiosity, thoughts which rapidly changes from one topic to another. He will have the excessive self confidence and also the arrogance. So this is about the crazy thoughts. The next symptom that you know is the excessive activity as well as the energy. Because of the excessive activity and energy, he'll have lots of ideas that in the mind. He will mind the other person's business, and also is actively passionate. Whatever he does, whatever activity he does, he loves to do it, but he will end up with incompletion of the task. He is always active and busy all the time, but he will end up, incompleting the task, and also he will be over generous and he will do the excessive shopping. Okay, over generous in a sense, whatever he has, he wants to give it away, right? So you don't give your things to a stranger, right? So whatever he may, simply distribute the money or simply give away the objects, whatever he or she has, right? So he's over generous, over friendly, and he does the excessive shopping, right? If you take the female patients, they are very fond of the makeup and dressing. Whatever the dressing that they, do will be a flamboyant way or grandeur way of dressing, right? So grand dresses that they wear, which is not matching with the event or the situation. Even the makeup for that matter appears to be very bright, and the jewelries or the ornaments which they use, which will be over adorned ladies that you can notice. However, they don't maintain the personal hygiene, right? Yes, some appear to be very carefree and have a strong sexual desire towards the opposite sex. So they are energetic throughout the day. They don't even need, time for sleep. So they have a decreased need for sleep, and also appears to be extraordinarily energetic. So these are the symptoms that you can notice if the client is having BPAD with the current episode of mania. Moving on to the depressive state. So when the patient is having BPAD with the current episode of depression, you can notice these following symptoms. The first important symptom is the low mood, right? Patient appears to be very sad, depressed, and indifferent. He is very pessimistic. That means he is or having the negative cognition. It can be towards himself, towards others, towards the environment, right? So negative cognition or pessimistic way of thinking he or she may have. They'll be desperate about the routine matters. They will lose the affection to the friends, the relatives, or the neighbors. They don't maintain that relationship. They feel very hopeless about their daily life and also about the future. They try to avoid the contacts with the friends and the relatives. The next symptom you can notice is the slow thinking. If you take the thinking of such a kind of a depressed patient, even their thinking will be very slow. If you go and talk to such kind of clients, you appear to get a response very, slow. They take a longer duration of time to give you a response. They'll have a closed thinking. They also have the feeling that his or her brain is not working properly. They have a difficulty in remembering and also in the concentration. They also just talk by whispering, not even moving their lips. Okay, they don't even want to move their lips within themselves. They start talking, okay, which seems to be like whispering. One may also develop the unsound idea that they have got a serious disorder which cannot be cured. If you take the energy as well as the activity level of such patients, they do the very few activity and they appear to be lethargic throughout the day. They feel very, unenergetic. They love to be alone in the room. Sometimes they don't even want to eat or drink anything. Always they need to be taken care by the other people. Sometimes when the depression becomes very severe, you can also notice the suicidal symptoms the patient may develop. The suicidal ideas, thoughts, or the behavior. So these are the symptoms that the patient will experience when he is having BPAD with the current episode depression. Right? So if the patient is having BPAD mixed episode, both the symptoms of mania and depression you can notice in the client. So this is about the clinical features of BPAD. Moving on to the treatment part. So when it comes to the treatment, you have got the three important modalities. One is the use of the psychopharmacological agents. The second one, we have the ECT. Third one is the psychotherapy. When it comes to the medication therapy, the drug of choice for treating this condition is mood stabilizing group of drugs. We have the drugs like lithium carbonate, the sodium valproate. We also use the antipsychotic group of drugs if the patient is having the psychotic features, BPAD with the current episode mania or depression with the psychotic features, then we'll be also adding the antipsychotic group of drugs. For example, the haloperidol, chlorpromazine are used as a tranquilizers. If the patient is having the BPAD with the current episode depression, we'll be using the antidepressant agents, the various classification of antidepressants that we have. Number one is the TCAs, that is tricyclic antidepressant, such as the amitriptyline, imipramine, nortriptyline. These are drugs which are commonly used to help, which is going to help out in correcting the imbalance of the neurotransmitters. So, especially it is targeted towards the serotonin and the adrenaline neurotransmitters, so which is going to bring about a balance in those neurotransmitters to combat with the depression. If you take the side effects of these TCAs, we have got the drowsiness, thirst, constipation, blurred vision, difficulty in urination, fatigue, and weakening of the memory. So that is about the TCA group of antidepressants. The next group of antidepressants is the SSRIs, selective serotonin reuptake inhibitors. So we have got an example of the drug, paroxetine. This drug is usually given to raise the concentration of serotonin in the brain, which will reduce the symptoms of depression, right? So if you take the side effects, this group of drug is having fewer side effects compared to the TCAs. The next group of antidepressants, we have serotonin, norepinephrine reuptake inhibitors. So this group of drugs is again going to increase the brain concentration level of the serotonin and noradrenaline. Example of this group is venlafaxine, duloxetine, right? So this is about the serotonin, norepinephrine reuptake inhibitors. The next group we have norepinephrine dopamine reuptake inhibitors. So it's based on the neurotransmitter, this group of drugs, okay, on what neurotransmitter it is acting. So they've given the name. So example of this drug is the bupropion. It will help in raising the concentration of the brain adrenaline as well as the dopamine level, and also it will have an impact on the brain serotonin level. Okay, so this is about the NDRIs. So that was the group of antidepressants that we use in the BPAD with the current episode of depression. Along with that, if the patient is having the feeling or the symptoms of anxiety, fear, we do administer the anti-anxiety agents. This includes the benzodiazepine group of drugs. If the patient appears to have acute agitation, restlessness, or simultaneously if the patient is having generalized anxiety disorder, then we do administer the benzodiazepine group of anti-anxiety agents. So that is about the medication therapy or the psychopharmacological agents. We'll be using the mood stabilizing drugs, we'll be using the antidepressant group of drugs, antipsychotic drugs, as well as the anti-anxiety drugs based on the symptoms whatever the patient is experiencing. Moving on to the second modality of the treatment, which is the therapist, okay, psychotherapist. So the type of the psychotherapy that is opted is the cognitive behavioral therapy. So here the CBT. Okay, so which is used to bring about a modification in the cognition. So when the cognitions are modified, even the behavior of the client can be modified. So it is a combination therapy, the cognitive as well as the behavior therapy will be given to the client to change those cognition. It can be the pessimistic way of thinking, the negative cognition, or the thinking of hopelessness, helplessness, worthlessness, suicidal ideas. So all these thoughts or the cognition has to be modified. So thereby even the behavior of the client can be modified. So that is the purpose of this cognitive behavior therapy that we give here for BPAD. The next modality of treatment, we have the electroconvulsive therapy. If the medication therapy fails for treating the BPAD conditions, then we opt electroconvulsive therapy. This is specially done for the client who is having the severe depression with the suicidal ideas, who cannot be managed with a drug therapy. We will opt for the ECT. So via ECT, electric current will be passed to the brain and thereby will be bringing some changes, artificially induced grand mal seizure, which brings about changes in the neurotransmitters, right? So that is the electroconvulsive therapy that we give. So that is about the treatment modalities for the BPAD. Moving on to the nursing management. So when it comes to nursing management of BPAD, it's very important that first thing you do the assessment. So what is this assessment? So via the assessment, you're going to diagnose the condition of the client, whether it is bipolar affective disorder, manic type, bipolar affective disorder, depressive type, or is a bipolar affective, the hypomanic type. You're going to find out through the assessment what type of the BPAD the client is suffering from. So it's very important to instruct the client to record his mood state, because in BPAD there is a change in the mood which happens, right? You need to instruct the client to record the mood swings or the mood changes, or even for that matter, you can ask the friends or the family to record the changes in the mood, which will aid in the diagnosis of the condition. If the client is to be diagnosed as having the manic episode, the following symptoms has to be noted. One is a distinct period of the elation, expansive, irritable mood, at least for a period of 1 week. So during the period of mood disturbance, the following 3 to 4 symptoms should be present in the client. Number 1 is inflated self-esteem or the grandiosity. Second one is decreased need for the sleep, wherein the client rests only for about less than 3 hours. More talkative than usual, then also he will be having the pressured kind of a talk. He'll have the flight of ideas or lazy thoughts, distractibility, increased goal-directed activity. It can be the social-related work or in the occupation, or if he's a school-age, teenage person, school activities. He will have psychomotor agitations, excessive involvement in the pleasurable activities, which will end up leading to a painful consequences like buying spears or involving in foolish business, sexual indiscretions. So such kind of activity. So if the patient is having any of these symptoms, 3 to 4 symptoms in the client along with the mood disturbance, then you diagnose him as having the manic episode. So these symptoms should not have any criteria of a mixed episode. So he should not have any symptoms of depression. It should be purely of these symptoms. These mood disturbance should be sufficient or to such an extent that it should cause an impairment in the social functioning or occupational functioning, in the personal functioning. It should cause some kind of an impairment or disharmony. The symptoms should not be because of influence of any kind of the drug or substances, purely because of the etiology. So if these symptoms are there in the client at least for a period of 1 week, then you diagnose the patient as having BPAD with a current episode mania. The second one is the hypomanic episode. So here the symptoms which you have to notice is a consistent or persistent period of these elevated, irritable, expansive mood at least for a period of 4 days. So there should be persistent mood changes. It can be in the form of, talkativeness, energy, or the speech that he uses, flight of ideas, lazy thoughts. Okay, such kind of symptoms that should be there, at least 3 to 4 symptoms which we noted in the mania, same symptoms. Along with that, should have some changes in the usual functioning pattern. Can be the personal life or the occupation, social life. There should be an impairment in the functioning. And the symptoms should not be direct influence because of some physiological use of the substances, right? So that is about the hypomania. The last one is a depressed state. So when will you diagnose the patient is having BPAD with the depression? The patient should have the following symptoms, at least 4 or 5 symptoms that you have to notice in the patient for a period of 2 weeks. At least these symptoms like depressed mood, loss of interest or pleasure. If you take the depressed mood, the patient should have throughout the day that most of the time he feels depressed. So he should have feeling of sadness and emptiness, and also others should notice that he is having this depressed mood. He should also have a markedly decrease in the interest or anhedonia, that he should have loss of pleasure in the pleasurable activities for almost all the activities throughout the day. You can also notice if the patient is having weight loss or weight gain. Decrease or increase in the appetite every day should be noted. You should also note the sleep pattern of the patient, whether he is having insomnia or hypersomnia, psychomotor agitation or psychomotor retardation, fatigue or loss of energy every day, feeling of worthlessness, excessive guilt feeling nearly every day if the patient is having, that you have to notice, decreased ability to think or concentrate, recurrent thoughts of death or suicidal ideas, or any episodes that he had made an attempt for a suicide or specific plan for committing a suicide, that you have to find it out. So these following symptoms should be present, at least 4 to 5 or 5 to 6 symptoms should be present for a period of 2 weeks, then you get diagnosed as having depression. Apart from this, the symptoms should not have any kind of mixture from the mixed episode. No other manic symptoms should be noticed. And also, there should be an impairment in the areas of functioning. It can be social functioning, occupational, or the personal life. There should be an impairment in the functioning. The symptoms should not be due to the direct effects of the substances of abuse. So this is what you need to observe, and you need to find out via the history collection, so that you can categorize what type of BPAD the patient is suffering from. Right? So that is one of the nursing assessment that you're going to do. Apart from that, you're going to, give the health education to the client as well as the family. Number one is you have to make the patient and family understand about the bipolar affective disorder. Very important, the family should support the client. So the family should be educated about the condition bipolar affective disorder. There may be frequent change in the mood. Also, they have to keep a record about the changes in the mood which happens rapidly and report during the follow-up visits. And whatever the treatment plan is given, the family should support the client to have a drug compliance, not to quit or stop any of these medications immediately without the notice of the psychiatrist. The second thing that you're going to educate them is to be alert about the warning signs of the relapse. It doesn't mean that once the treatment course is completed, the patient doesn't get the disorder again. No, there is a high risk for the relapse, especially in the BPAD. You may not know what episode will strike the client. So always be ready, educate the family about the complete disorder of BPAD, depression type or the manic type, mixed type. So notice what are the changes in the mood and behavior of the client, and find out if there is a relapse, within this particular months, what kind of episode the patient can get attacked with. And to prevent the relapse, see to it that the drug compliance is taken care of. The next thing you educate is to avoid drug or any kind of alcoholic drinks or the abuses. So these drugs or alcohols, when it is taken, it will increase the risk of recurrence of the disorder. So you have to educate them to avoid these alcoholic drinks or any kind of the drug intake. Educate them to follow strictly the doctor's instructions related to the medications, about the drug compliance, about not quitting the drug immediately, about changes that they want to have in the dosage or changing the medication because of the side effects. Anything related to the drug change that they want to have, they should inform the psychiatrist, and with his consent only should there be changes in the medication regimen. The next thing is to take care in taking other drugs. Say, for example, the patient develops any other disorder or a disease, right? Medical related disorder or a disease. He should have a consultation with the psychiatrist and then only start the medications for those disorders. The next one is participate in patient support group. So in the patient support group, we have got a group of patients who had already been suffered from this condition, BPAD, manic type or depressive type. So when such a patient is involved in the group, he will get an idea about how they have overcome this disorder, and it is possible for the client also to overcome this condition, right? He gets a confidence and a idea that he will not have this problem permanently. Yes, so to boost him and to instill that positive thinking in him, so involve him to participate in such kind of a group therapy. The next one is to build up the healthy life. So always the natural hormones, the happy hormones, the endorphins will be stimulated when he goes for a regular exercise or any kind of activity that he feels to be passionate about, a hobby that he can take up, which is going to stimulate or release the endorphins, which are going to calm down the condition of the client, which is going to reduce the tension and make the patient to feel pleasurable and relaxed all the time. Apart from that, even about the diet therapy, the balanced diet that he has to take to maintain a good physical as well as the mental state. So these are some of the education that you're going to give to a client. So BPAD is a condition wherein the client will have both the conditions of mania and episode in the same patient, but during the different times, which appears as a different episodes, right? So very important as a nurse to educate the client about the drug compliance and the follow-up, which is really going to help him to avoid the relapse or the recurrence of the disorder. Hope you all have understood the topic. Thank you.